Dr. Patel, Jyoti, tell me what a general oncologist, what do you think they would do in all of this technology that's out there? You know, how do you run lung cancer? What do you want to do in lung cancer patients?
So I think you really need multidisciplinary buy-in. So you need good conversation with the pathologist. They need to understand the clinical relevance of these oncogenic drivers and why we prioritize them. I think one reason so many of us medical oncologists have gravitated to blood-based testing is we control it, right? We can send a nurse to someone's house to get the blood, results come straight to us. We can look at the time flow and make it happen according to our needs. With pathology, it can be more cumbersome. Like some institutions, ours, you know, have been able to do reflex testing for all adenocarcinomas at diagnosis or all non-squamous cancers at diagnosis, and then special one-offs. That takes shared effort and decisions about what you can do in-house, what needs to be sent out. So I think initially, you know, that piece of there's a new diagnosis at tumor board, what does the general oncologist do is talk to the pathologist. How soon can you get this tissue? Because you may ask for a send out lab, but it may sit in the lab, particularly during these crazy times, for a week before it even gets sent to the outside laboratory. So I think some sort of workflow within your institution that makes sure these happen quickly is absolutely essential.
So you work at Northwestern, right? And are the pathologists giving you trouble at Northwestern?
No, it's been great, right?
Okay.
So we've been able to buy into a shared model of reflex testing that they help us control tissue. We have shown, and multiple others have shown, that if you have that, it shortens the time to treatment initiation and to getting results, obviously, right? Not looking at in-basket. But whatever institution get there.
Yeah, Luis?
I have a comment to complement what Jyoti is saying. You're talking about our institutions where we have certain authority to ask the pathologist that can be your friend, please send the tissue. But remember, all of us are referral centers. So a lot of the patients that come to our centers, because they're very large centers, come from a hospital, you know, that from some city that is around you, and you don't have any authority when you request the tissue to have the tissue delivered where you want to send the testing. So that's a main problem. You know, if the referral hospital wants to send the tissue 3 weeks from now, there is no way other than to call them and ask as a favor to do it. You know, that's a major problem that we have. That's why the plasma is very helpful sometimes, because we can send it right away.
Yeah, and I think that, go ahead, Mark, I'm sorry.
Well, yeah, no, I agree with Luis. You know, but that's part of the reason why there's a particular vendor that will go directly to the source of where the tissue is. I call them the golden retriever of molecular testing vendors. You just throw the tennis ball to that hospital, they go get the tennis ball, and it just takes us out of the loop. They still have trouble getting it quickly, but at least they take us out of the loop.
Yeah, there was an interesting time when I sent a test on a patient. He was a physician, and it was his own institution where his tissue was, and his pathologist wouldn't release the tissue. Yeah. And so I had to call the pathologist, and they sent the block to me. And then so you know, we don't want to get in the weeds of that, right? It really is a barrier to, say, getting access and getting it sent out. Tony, let me ask you a sort of hard question about this, because you love pancreas cancer, or hate it, should I say. You know, not uncommon for us to have a very small amount like the lung cancer folks get. What's it worth doing to get tissue enough to send for broad testing? You know, do you go for a repeat biopsy? You know, do you try to use circulating markers? Tony, what are you doing in pancreas cancer when you don't have enough tissue?
Yeah, so this is a very particular challenge in this type of cancer. The problem is the liquid piece is even more challenging in pancreas cancer than other cancers. I mean, these tend to be low volume types of cancers, and they shed very little DNA. I mean, you find them, but they shed very little DNA, and the return is actually not as powerful. That said, you know, we've used it. And many times you find what you would expect, no alterations because you can't find the DNA. I actually tried everything possible to have a tissue biopsy on these patients. So even if the tissue is scanned, so first of all, we trained our gastroenterologists, but as you know, we're saying most of these patients may come with their tissue already or whatever tissue they got. But for our patients, even in the locally advanced, where you typically have endoscopic ultrasound, you have very little tissue, we've actually have trained them to try to get a larger core, like a 19 rather than a 22 or a 20, 25, whatever they use, to actually give us enough to be able to run a test. For those with liver lesions, which again, most of those patients with metastatic disease will have liver lesions. If they just had an endoscopic ultrasound with scanned tissue, I'm doing a biopsy on the liver. And I think it's justifiable. Now, one may argue with pancreas cancer specifically, say, well, most of these patients will have nothing. Well, but for the 10% or 15% that will have something, it could be quite significant. It could be an NTRK fusion. It could be MSI high. I mean, those are 0.5 to 1%. But you know what? We find them. They have remarkable responses. We're finding HER2, we're finding BRAF, and now NRG fusions, which certainly, in the lung world as well, are becoming relevant, and there are trials. RAS G12C. So these are little pieces, needle here, needle there, but ultimately, and then BRCA, BRCA and PALB that are actually somatic, not germline. So even if we test germline and they're negative, you still have a 50-50 chance if they have a BRCA that the BRCA will be somatic, not germline. And those actually respond equally well to the PARP inhibitors. So if you put all this together, there's about 10 to 15%. So it's not the majority, but for a disease that does incredibly bad, these are important because they help us and direct us in terms of treatment. So I'm very aggressive with trying to get a biopsy on those patients, whichever way I can.
Yeah, so it goes back to Jyoti's comment about this sort of team multidisciplinary approach. I bet every one of us would nod that, we have a deal with interventional radiology if they're down there for tissue, not just for diagnosis, but for profiling. It's really changed the SOPs in many ways of referrals for tissue acquisition. And so I think that it's just critical for us all to do that.